Welcome back to Clinical Intelligence for Attorneys. I'm Michelle Carroll. Today's subject is one that should be on every plaintiff attorney's radar: chemical restraint. When a nursing home administers an antipsychotic to control a resident's behavior for staff convenience, rather than to treat an adequately documented medical symptom, the medication may become a chemical restraint. The harm can extend far beyond sedation. It may contribute to falls, fractures, aspiration, reduced mobility, functional decline, and a loss of the resident's ability to engage with the people and world around them. In this episode, I'll show you how to trace the medication through the physician's orders and medication administration records. Examine the documented indication and attempted alternatives. Connect changes in the resident's condition to the medication timeline, and frame the evidence within the clinical and legal standards that govern unnecessary psychotropic use. Okay, so here's something that's been on my mind. Nearly 20% of nursing home residents in the US are prescribed antipsychotic medications, even though most of them don't have conditions like schizophrenia or bipolar disorder that would warrant it. That's a huge number, and it raises some serious questions about what's really going on in these facilities.
Oh wow, I didn't realize it was that high. That's a staggering statistic. So, are we talking about over-medication here? Or is it something even more deliberate, like using these drugs as a form of control?
It's both, really. The term chemical restraint gets thrown around a lot in this context, and it's exactly what it sounds like: using medication to sedate or control someone, not because they need it for their health, but because it makes them easier to manage. And in nursing homes where staff are often overworked and under-resourced, it becomes a quick fix.
That's such a disturbing thought. These are people who are already vulnerable, and instead of being cared for, they're essentially being subdued. What's driving this? Is it just about convenience for the staff, or are there other factors at play?
Convenience is definitely a big part of it, but it's also systemic. Nursing homes are often understaffed, and caring for residents with dementia or other cognitive impairments can be incredibly challenging. Instead of investing in more staff or better training, some facilities turn to medication as a shortcut. And let's not forget the role of pharmaceutical companies, who have a history of aggressively marketing these drugs for off-label uses.
Right, I've read about that. Antipsychotics were never really designed for this kind of use, were they? They're meant for serious mental health conditions, not for calming someone who's agitated or confused.
Exactly. And the thing is, these drugs come with serious risks, especially for older adults. They can cause sedation, confusion, and an increased risk of falls. In some cases, they've even been linked to strokes and higher mortality rates. So it's not just about the ethical implications, it's also about the very real harm these medications can cause.
That's horrifying. And I imagine it's not always obvious to the families of these residents, right? They probably don't even realize their loved ones are being over-medicated.
That's one of the most heartbreaking aspects of this. Families trust these facilities to provide the best possible care, and they might not question why their loved one seems more sedated or less responsive. They assume it's just part of aging or the progression of their condition, not realizing it could be the result of unnecessary medication.
So, what's being done about this? Are there any regulations in place to prevent this kind of over-medication, or is it just slipping through the cracks?
There are regulations, but enforcement is a whole other issue. For example, the Centers for Medicare and Medicaid Services have guidelines aimed at reducing the use of antipsychotics in nursing homes, but compliance varies widely. Some facilities have made progress, but others find ways around the rules. And without consistent oversight, it's hard to hold them accountable.
It sounds like a classic case of a systemic problem, one that's not going to be solved with just one or two changes. What would it take to really address this issue?
It's going to take a combination of things. First, we need more transparency. Families should have access to information about how often these drugs are being prescribed in a given facility. Second, there needs to be better training for staff on how to manage challenging behaviours without resorting to medication. And third, we need to address the root causes, like understaffing and lack of resources, that make this kind of practice so tempting in the first place.
That makes sense. And I imagine there's also a need for cultural change, right? A shift in how we think about aging and elder care so that we're prioritizing dignity and quality of life over convenience.
Absolutely. It's about recognizing that these are people, not problems to be managed. They deserve to be treated with respect and compassion, not medicated into submission. And that's a mindset shift that has to happen at every level, from individual caregivers to policymakers.
It's such a tough issue, but I'm glad we're talking about it. I think a lot of people just don't realize this is happening, and awareness is the first step toward change.
That's exactly right. The more people know about this, the more pressure there will be to address it. And hopefully, that leads to real meaningful change, not just for the residents, but for their families and the staff who care for them.
Well, I think you've made a pretty compelling case for why this issue deserves more attention. Let's hope it sparks some conversations and some action.
Agreed. Thanks for diving into this with me. It's not an easy topic, but it's an important one. Let's keep the dialogue going. A chemical restraint case cannot be established simply by finding an antipsychotic on the medication list. The analysis depends on why the medication was ordered, what symptoms were documented, whether non-pharmacological interventions were attempted, how the resident responded, and whether the facility continued the medication despite evidence of harm. The physician's order begins the inquiry. The medication administration record establishes exposure, nursing assessments, behavior monitoring, care plans, pharmacy reviews, gradual dose reduction records, and adverse event documentation help reveal whether the medication served a legitimate clinical purpose or was being used to make the resident easier to manage. When the medication timeline is aligned with falls, fractures, aspiration, sedation, functional loss, or cognitive decline, the record may reveal both the nature of the violation and the human consequences that followed. Thank you for joining me for this episode of Clinical Intelligence for Attorneys. I'm Michelle Carroll, founder and chief clinical strategist of Lexcura Summit. To learn more, visit lexcurasummit.com. Lexcura Summit, clinical intelligence for better litigation decisions.